We live. All right. Good afternoon, ladies and gentlemen who have joined us on this Dr. Fundi channel via multiple social media platforms, Facebook, YouTube, Instagram, Twitter, and also the Dr. Fundi website. Today, I've got an interesting show in prospect. I've got a special guest, Dr. Tejini Naidu, who is a registrar in the Department of Psychiatry at the University of Natal Medical School. Dr. Naidu has had some research published in an online research publication platform called PLOS ONE a few weeks ago. She did research, but she did research on burnout, on anxiety, on depression amongst medical colleagues at 5 teaching hospitals in KZN. Now, reading that article, I felt she is the right person to be our guest this afternoon to shed more light about what motivated her to actually do the study. How was the whole process of doing the study, but also shed some information around the findings and the relevance of the findings, within the medical profession going forward. So, Dr. Tejini Naidu, welcome to the Dr. Fundi platform.
Thanks, Dr. Nyati, for inviting me.
All right. So, Doc, it's not going to be a very formal kind of interview. Like I said, it's colleague to colleague. What is important is more, enlightening people about, the work that you have done, so that, they can be able to better understand the challenges that medical doctors face in the workplace. And also, if there are colleagues who are watching, then can be able to also see from your recommendations what are the things that they can actually apply in their own lives. And if there are some administrators of the hospitals or departments, provincial departments who are actually influencers or decision makers, they can be able to see what is it that they can do to better look after, the medical colleagues within their areas of responsibility. All right, so to kick off our discussion, I just want you to just share with our viewers, you are a registrar, that is a specialist in training in the Department of Psychiatry, UKZN. Can you just tell us a little bit about what made you to choose to specialize in psychiatry, just as an opening, statement?
Okay, so I started my medical training in Stanger Hospital, which is now General Justice Mpanza Hospital. And I did my internship, community service, and medical officer years there. And when I was in my community service year, I obviously had to decide which specialties I was going to apply to. And it just so happened that there was a post in psychiatry and there was a post in emergency medicine and anesthetics. So I was accepted for the emergency medicine post and the psychiatry post. And I just wrote a list of pros and cons because I wasn't sure which one to choose. And I ended up working in psychiatry, and I wasn't sure if that's actually what I wanted to do. But over the years, working in psychiatry as a medical officer, I found that the levels of job satisfaction was very high in the discipline. And so that pushed me to do my diploma in mental health. And after doing that, I further understood, what mental health was, what mental illness was, and how best to treat my patients. So I would say overall, it's the level of job satisfaction that I receive from treating patients and helping others that enabled me to get into this discipline.
Lovely. But let's just go back at the time you were looking at, emergency medicine, psychiatry, emergency medicine, psychiatry. What were the cons that made you not to go for emergency medicine? The head of emergency medicine is a a guy that I qualified with in 1989.
Okay.
So I feel for him. It's Prof. Bonga's game.
Yeah. So I think it lends itself to the type of person you are. So I tend to get stressed quite easily. And even though emergency medicine does have a high level of job satisfaction, I mean, you're saving lives acutely. I just found, because I was doing calls in emergency medicine, even though I was working in psychiatry during the day, and I found that it would take a toll on my mental and physical health doing those calls, and I would be more irritable than usual, the lack of sleep, lack of eating. So I just felt, for me, it wasn't a correct fit. I mean, it's a wonderful discipline to go into, nothing against emergency medicine. It's just that in terms of my personality and what I could manage, I definitely felt psychiatry
it demanded more out of your energy levels.
Yes, no, I could manage the calls. It's just overall, I just felt on a balance of pros and cons that psychiatry was definitely a better fit for me.
Yes, well, definitely it is, because when one looks at the work that you've been doing already as a registrar, and I happen to also look, and there's some work you did even before the one we're going to talk about today in relation to medical students, and maybe we might touch on that. I think you presented it somewhere with Prof. Bonga. Must have been a year or so ago. So it seems like you are actually in the right place. But anyway, let's get to the main reason for the conversation today. So, Doc, you were doing your master's, your MEd. Is it MEd?
Yes, correct.
Yeah. And as part of your requirements for the master's program, you had to do some research so that you can have a dissertation, as part of the qualification. So how did you come to decide on this particular topic? And in fact, maybe before you answer that, what was, just for the viewers, what was the topic? How did you come to decide on that topic?
Okay, so I'm just going to go back before my reg time. So I think where I actually took an interest in my own health began in about 2014. And I was diagnosed with pulmonary TB in about September, October in 2014. And although it didn't feel very good at the time, I think in retrospect, it was actually a good thing for me, because it caused me to pause and reflect on why this had happened. And when I reflected, I realized that I was highly stressed. I wasn't eating properly, wasn't sleeping well. I got married that year, and I was studying for my diploma in mental health. So there were a lot of factors going on, and it actually pushed me to, eat better, exercise well, and take more of an active interest in my own mental and physical health. So from that point, for reflection, going further back, I realized that, I had had gastritis before, I had had headaches before, and all of that was stress related. So my love of mental health, in terms of myself and my colleagues as well, not just in general, it started at that point. And so when I entered the program in 2017, I came across an article about perfectionism and anxiety in medical students, and I said, this is what I want to do. I want to look at mental health in either medical students or doctors, but basically in colleagues, because it's not talked about very often. It's highly stigmatized, and it's something that I really want to do. And so I got a supervisor, Dr. Paruk, who kind of guided me and enabled me to shape my topic a bit better. And so we came up with burnout, anxiety, and depression in medical doctors. And that's how it came about.
All right. And so that was the first time you were involved in research, your research.
Yes.
And so Dr. Paruk was your supervisor. Lovely. So you had to write your protocol. Just take us through that journey before you actually did the work.
Okay, so I started in 2017, and in my first semester, I did my primaries. And something that resonates with me is that Dr. Paruk said to me, semesterize your goals, because I think being a registrar can be quite overwhelming. So if you just set targets for yourself, it's okay if you fall a bit short sometimes because there are unexpected circumstances that occur. But I just tried to semesterize my goal. So my goal for the second semester in 2017 was to develop my protocol and submit it to BREC for approval. And honestly, the biggest blessing I had was a great supervisor. I can't sing Dr. Paruk's praises enough. She was really a guiding light in terms of, how to shape the protocol and basically what it entailed. We did get a protocol template from Prof. Colleen Aldos from the University of KwaZulu-Natal. So basically, I just started off reading around the topic and doing a literature review on the topic and why this research is actually needed and what our aims and objectives were. And as I said, Dr. Paruk and Dr. Tumita as well were instrumental in the development of the protocol. So that's how my journey went.
So what were the objectives and aims of your study?
Okay, so our study aimed to ascertain the prevalence of burnout, anxiety, and depression in medical doctors working at 5 KwaZulu-Natal training hospitals. And then we wanted to look at the associations between each other as well as, individual and organizational factors as well. So those are the main sort of aims.
Yes. All right. Lovely. And so the size of the sample that when I read there's about 150, people participated in the study. Was that, from the epidemiologists and statisticians, or whatever? Just.
Yeah, so Dr. Tumita was our brilliant statistician. So he said 150 would be a statistically significant sample size to sort of get. But more than that, it's just really hard to recruit doctors to take part in studies because they're so busy. So it was quite a mission to actually get doctors to participate. My response rate wasn't very good, and I opted not to go online because I thought that it would be better if I actually engage on an individual level with the doctors to get a better sample. But my response rate was still 47%. So there was quite a large proportion that didn't return surveys or they didn't qualify. So we did end up with 150 participants at the end of it.
All right, but that's still good enough. I think that's still good enough. All right. So normally that process of getting the protocol approved can be nerve-wracking. The corrections and to and fro from the ethics committee and stuff. How was it for you? I mean, was it just
was tiring.
Everything was good, or there was a to and fro?
So it took 6 months, and I think the main reason was because we had chosen to do it at 5 different hospitals. So we had to get provisional BREC approval first, then we had to get provisional approval from all 5 sites, then provisional approval from Department of Health, and then full approval from BREC before starting the study. So I think it was quite a bit of work. So for 6 months, we were just waiting for approval, basically.
I think 6 months was reasonable. Yeah, I mean, considering all what you had to go through in terms of the approvals that you needed from all these centers. All right. So when you got that email that said it's all systems go, now you can go ahead and do your study, how did you feel?
I was excited, but obviously I had to think about the practicalities of data collection, because I think if you speak to anyone that does research and is actually doing the data collection themselves, they'll tell you that that's the most difficult part of the study. The protocol and the approval and stuff, that will take time and it'll happen. But in terms of data collection, it can be quite nerve-wracking as to whether you'll get your numbers, going out in the field every day, trying to convince people to take part in your study. So I felt great, but I also was grounded in the fact that practically it may be a bit difficult to get the numbers.
All right. And so how long did it take for you to actually gather the necessary information, from your subjects to a point where now you could sit and do your analysis and other things?
So when I started data collection, I was actually pregnant in my second trimester. So it was a bit more tiring than usual. But so I started data collection in September 2018. And I had my baby in December, and I completed my data collection in January 2019. And as well, as a fact, as I was actually in Ngwelezana for the last 3 months of the year. So I had a few hurdles, but thankfully I managed to overcome them, and I was able to collect the data.
No, they normally say, you guys of the fairer gender, you are able to multitask, so there you were. with all your anxieties, but you still were able to do all these things, you know? Yeah. And so, yes, um, you were done with your data gathering and you had to now sit down and work with, analyzing and doing whatever. How long did it take you to actually have the complete product?
So after the data collection, until the completion of write-up, I would say it took about 10 months, but that's more because I was lazy than anything else. I was just like on a go slow because I was on maternity leave. But yeah, so I input the data. And then Dr. Tunita did the analysis, and then we completed the write-up by October and submitted it to UKZN as part of my dissertation.
Yeah, is it October last year?
Yes, correct. October
19.
last year. Yes,
All
yes.
right. And you were just crossing fingers now. That
Yes, just waiting for, yes, yeah.
but I mean, you were working closely with your supervisor, so and she's quite experienced,
Yes.
So I'm sure you were pretty much confident that it won't get too much of challenges from those who needed to approve it.
Yeah,
Okay,
no,
okay. So we are at that point now where you need to share with our audience what were the key findings of your study, Doc. What were the key findings? Because we need to look at those key findings, get to know what do you think were the drivers of those findings, and also what needs to be done at an individual level, but also at a organizational, or health system level. Yeah.
Okay. So the key findings of our research was that burnout, anxiety, and depression are highly prevalent in medical doctors working in KZN and training hospitals. We found that the rate of burnout was 59%, which is quite significant. The rate of anxiety symptoms was 20%, and the rate of depressive symptoms was 21%. Furthermore, we found that burnout was positively correlated with an increased risk of developing anxiety symptoms and an increased risk of depressive symptoms. It was also found that junior doctors, particularly interns, were at higher risk of developing burnout, whereas older doctors were at increased risk of developing anxiety and depressive symptoms. We also found that in terms of gender, females were more likely to develop depressive symptoms, and medical officers were the group at highest risk of developing depressive symptoms. So those are the key findings of our study. And then you mentioned drivers.
Just before we get to that, I just want us to reflect on these findings. So you're saying basically 59% of the people had positive, they met the criteria for burnout. All right. Now, can you just say, again, for people who may not know what burnout is, and what are the critical aspects of burnout that one must fulfill to be given that diagnosis?
Okay. So burnout is quite a contentious issue because it's not a diagnosis. It's actually a psychological syndrome that results from chronic interpersonal stresses on the job. And there's different ways of defining it, but I'm going to use the gold standard, which is looking at 3 components of burnout. Yes. So the first component is emotional exhaustion, which is the intrapersonal component of burnout. It's just feelings of extreme fatigue, both mentally and physically. And then if you have high levels of emotional exhaustion, you're at increased risk of developing burnout. The second component is depersonalization. So this is the interpersonal dimension of burnout. So it's feelings of inadequacy on the actual job. And again, increased sort of scores on this component indicate an increased risk of developing burnout. And then the third component is personal accomplishment. So do you feel like you're really being impactful in that given role that you have? Are you accomplishing something? And low levels of personal accomplishment correlate highly with burnout. So those are the 3 components.
So the 3 areas, the emotional exhaustion, depersonalization, and the one around competence, really, or declining productivity. All right. Now, you said earlier it's a contentious issue, in terms of diagnosis. Now, in July last year, the guys who come up with the international classification of diseases, they actually, for the first time, recognized burnout as an occupational, disease, right?
Yes.
That is as something that can label a diagnosis of some kind in the workplace. All right. I talked about this with somebody earlier today. I was on the radio on 702 FM. And this person was saying, so are you saying if I'm not in an occupational environment, I can't use the word burnout if I'm busy working at home and I'm juggling so many things? I said, well, technically, it's just the workplace. But anyway, the issue about this 59% burnout amongst the colleagues, that is your finding. How did it correlate? Obviously, you did background, studying of other researchers that are in the same area. So comparing these findings with other studies, similar studies across the country and maybe beyond, how did it compare?
Okay, so internationally, our rate of burnout correlated to international studies, as well as our rates of anxiety and depressive symptoms.
Yes.
But in the South African context, our study showed a lower rate of burnout than some of the other studies done in South Africa. And there are various reasons for this. So the two key studies were actually done in the Western Cape. And the first one was done in Red Cross Children's Hospital in 2011. And that one had quite a small sample size and only sampled junior doctors. And the way in which they defined burnout was slightly different from us. So they had 100% sort of rate or in terms of who had either high levels of emotional exhaustion, depersonalization, or low levels of personal accomplishment. And then a 2013 study that was done in the Western Cape as well showed a 76% rate of burnout. And again, they mainly sampled junior doctors in their sample size, and the sampling strategy was slightly different as well. So those were some of the sort of key differences. Anxiety itself hasn't been sort of researched in our country in medical doctors as an individual component. So I can't really comment on that.
Yes, no, lovely. So again, I picked up that, I think in the UK, and even in the UK, they talk about between 25% and 75%. So your 59% is actually
it's within that range. Yes,
it's within the range. In the US, they've got this annual survey that they do, the Medscape National Burnout and Anxiety, whatever, study that they do. And last year, 2019 report, it said 44%.
Yes.
Of burnout. But you picked up that there's burnout, and then there's now, what do we make of the 20% that had anxiety symptoms and the 21% that had depression symptoms?
Okay, so in as much as I mentioned that there's contention about burnout, the scales that we used to measure anxiety and depressive symptoms are just screening tools. So it's not actually, I can't say the person was diagnosed with a disorder, but if they screen positive, they require further investigation to look for disorder, because obviously it's a clinical assessment that requires a structured clinical interview. But these screening tools have a high sensitivity and specificity for the cutoff scores that we used of more than or equal to 10. We use the Generalized Anxiety Disorder Questionnaire 7, which has been validated in our context. And we use the Patient Health Questionnaire 9, which is quite widely used, and it's validated in our context as well. So it's just merely a screening tool, but it was found that those symptoms were highly correlated with high levels of burnout.
Okay, all right. And so putting it all together, then the burnout level at almost 60%, that's 59%, and a fifth, showing symptoms that are talking to depression and anxiety. Putting it all together, what did it make for you? What impression?
That medical doctors are highly stressed. I think, the thing is that obviously across occupations, you do get different levels of burnout, but my interest was particularly in medical doctors. So As mentioned earlier, both individual and organizational factors play a role in this. But what we found that it was quite significant. And the significance of this finding is that obviously we'd want to aim now towards implementing individual and organizational strategies that could mitigate these consequences.
And what did you pick up as, drivers or possible drivers of what you saw in terms of the findings of 59% burnout, 20% anxiety symptoms, and 21% of depression? What was driving this, or what is driving this, from the study that you conducted?
Okay, so some of the factors that we found that predisposed individuals to burnout were a lack of clinical supervisor support, staff shortages, a high workload, poor working conditions, public system related frustration, and a lack of equipment. So those were some of the factors that the participants mentioned, increased levels of burnout.
Yes. And so there's some individual, but it's more organizational, dynamics within which doctors find themselves as they do their work. All right. And so having found this, you obviously came up with some recommendations on what must be done at individual level and what must be done at organizational level. Let's start with the organizational level. What are the kind of recommendations that were made in your study to actually, obviously you were doing your study within KZN. Do you think your findings from this study can actually be used, to look at a national picture, or other provinces?
So I definitely think that research in this area does need to be prioritized. I don't think that our findings are necessarily generalizable across all settings. So, you get doctors working in rural hospitals, you get doctors working in private settings. And so our findings may not be generalizable, but I think it's a good starting point because now we have a baseline of what the problem is pre-COVID. And obviously COVID causes its own issues. So,
yeah.
Yeah.
This was
so
COVID,
Yes. So I think it's a good starting point, and I really think that the Department of Health needs to prioritize, looking at what other possible drivers could be causing these mental health consequences that have a negative impact on these doctors across different health settings, and furthermore to actually implement strategies at individual and organizational levels. Some organizational strategies would be decreasing workloads, bettering work conditions, improving resources, and advocating for peer support groups. So at an organizational level, that is what we recommended.
Yeah. All right. And there's something that you mentioned around the Department of Health has to, I think, take the process forward or something like that. I can't remember exactly, but something to do with, based on your findings, there's something that you are advocating that the Department of Health should do.
Yeah, so I think that individual factors are one thing which we will get into in a bit, but at an organizational level, there's a reason why these doctors are burnt out. If you look at the conditions that they're working under, the shortage of staff and so on, that will come at a higher level. That on an individual basis, we cannot necessarily effect change unless we all come together and advocate for it. So I think really the change has to start from the top. And obviously, as I will mention, individual factors that we have control over that we can assist ourselves with.
Yes. All right. Now, did your study look into how the colleagues are coping with burnout? Was it part of your study to just look at what are the guys doing to try and deal with this? And to see whether that's actually appropriate ways of coping with stress, that has led to the burnout, or it was not part of the study?
So our study actually included several components. The components that we published are like sort of half of it.
Okay.
So we still have other elements that we looked at, but the questionnaire was very long. So we had a socio-demographic questionnaire, the Maslach Burnout Inventory, PHQ-9 and G87,
Yes.
and to even get them to fill out that was quite a mission, because I know they are overworked and overstressed. So we actually didn't look at what coping skills individuals use holistically, but we looked at sort of elements of it, but not at that per se.
All right. You know why I was asking you, Doc, but I mean I understand your answer. What I was asking you is because again, when one goes to that annual survey, the Medscape one, which is at burnout amongst doctors in the US, then they look at that part, and also I think one that was done in the UK by Medscape as well. But that one is linked to COVID-19, situation. But what they found was that quite a number of the doctors, when they were asked about how are they coping with this, quite a significant percentage of them, they talk about, food, they eat. Others, they choose mind-altering beverages, to take alcohol, as a way to deal with that. Obviously, somebody else will say those are maladaptive, type of coping, mechanisms or behaviors. So I thought maybe you guys looked at that as well,
So, yeah, sorry. So we did look at part of those things. Like we did have questions relating to substance use and some other elements, but it wasn't framed in that way. Like we didn't ask, do you use the following to cope, or what do you use to cope?
Oh, yeah, the
we
other
just
one
looked
is
at them.
exercise. The other one,
yes,
they used a lot of exercise as well. Yeah. Okay. All right. So now you have this information. You have published. Is it your first article to be published? In a recognized, platform like the PLOS One?
Yes, it's my first article in international journal. So
yeah.
yes.
And what does it mean for you?
So overall, research should be impactful. When you do research, it should be impactful. I don't really think it's helpful if you're just going to do research for the sake of doing research. And if you're passionate about something and you're hoping to have something good come of it, I think that's a starting point. So I'm really hoping that, yes, it's nice to get acknowledged and all the rest, but at the end of the day, what we're actually advocating for is destigmatizing mental illness in medical doctors, because in as much as the public stigmatizes it, medical doctors themselves stigmatize themselves when it comes to mental illness. Because even in our study, we offered mental health support services to these medical doctors, and not a single person took it up. Even now, with the advent of the COVID-19 pandemic, there is a healthcare workers care network, which is a toll-free number that people can phone. And as far as I know, no medical doctors, it was only nurses that actually access the help. So it really needs to be a change in the whole culture of medicine and the way that we perceive mental illness, particularly in medical doctors. And so that's what I'm really hoping will come from this work, and I'm hoping that other people would be inspired to do research in a similar field, looking at interventions that can be done in this area.
Yeah, isn't it ironic though that like you've got doctors, they deal with sometimes the end result of poorly managed stress and all of those things, where people now present with a mental disorder and stuff, but when it comes to our own health, we don't really prioritize the help-seeking behavior from doctors. Is not so great. Again, another thing that I picked up on that Medscape thing was that most doctors generally did not see the need to go and sit down with a therapist, and the females were better at help-seeking behavior than the males. So the question is, so the people are still medical doctors, but that issue of society creating that toxic masculinity thing amongst males, where as males we don't acknowledge stress, we don't actually acknowledge when we are depressed. Instead, we choose to escape, sometimes escape doing the wrong things. I mean, you would expect that amongst medical doctors, something like that would not really, happen. But the reality is that even when help is there for medical doctors, they don't pick, they don't take up those kind of, services. And it's really, then the question is, even if Department of Health would put up these things tomorrow, they may still be underutilized, you know. And that then the question is, what then needs to be done? I think you're right by saying maybe your study is one of those studies that must actually be internalized by medical guys so that they can relook their attitude towards issues of mental health broadly, and actually know that there is nothing wrong. It's not that you are weak to acknowledge that you are now at a point where your cup is actually empty, and you can't continue giving from an empty cup. You also need to fill up your cup, and maybe even learn ways and means of actually how to do that. Are there any, in your recommendations, are there any, ideas on how at an individual level people could improve their resilience or coping mechanisms?
So I think, again, we have to firstly destigmatize, again,
Yes.
Mental illness in medical doctors, because if you don't recognize that mental health is a part of overall health, and I say this quite emphatically because during the course of my data collection and even over the past few years attending conferences, people make comments that tell me that they don't understand actually what mental illness is, and they think that it's just something you can get over. So I think starting with that and just opening up the conversation about mental health and well-being and mental illness, I think that's really important. Educating and informing ourselves, and not being so ignorant about it, and being more sensitive to ourselves and others as well. So I think we'll start with that. And then in terms of an individual level, some evidence-based strategies include mindfulness, self-care programs, and sort of balance groups in small sort of settings that aim to enable or facilitate that support process. So I think one of the useful strategies is mindfulness, and that really is grounding yourself in the present, and actually paying attention to yourself, because a lot of the time medical doctors are just going on autopilot. We're just going through our day, we're just thinking about the past and what's going to happen. We don't actually ground ourselves in what's happening right now. So paying attention to our thoughts, emotions, and behaviors, and sensitizing ourselves to what that means. When I'm stressed, how do I feel? What do I think? What are my emotions? What are my behaviors? And just breathing in and out, taking that breathing space to just ground yourself in, where am I right now? What is happening right now? And bringing a gentle kindness to yourself, which I think often we don't do. So awareness is the first component. And the second component would be balance. So, I think that's extremely difficult. And in as much as you say that females have a bit, a bit more resilience in terms of balance, I'm not sure about that. It's very, very tough.
On the help-seeking behavior.
The housing. Okay.
Going to seek help.
Okay.
You guys are a little bit better than males.
Okay. No, definitely I agree.
If it's still sometimes when it's too late. And I mean, if we look at the numbers, now I'm talking to an academic, so I need to be very clear about what I'm saying. All right, but if you look at the numbers of people, the gender split amongst people who are committing suicide in this country, males are by far more than females. But when you look at the people who are diagnosed with, let's say, for example, depression or anxiety, females, they actually go forward, they get diagnosed, but when it comes to suicide, which may be a complication of those diagnoses, there's less females who are committing suicide, than males. Now, when you look at your findings, Doc, obviously your study was amongst medical doctors, but I would assume that other healthcare workers that are part of the health team may also be facing similar, type of challenges in terms of the workload, the long hours, lack of resources, and all of that. Now, in your reading, around your study, did you pick up anything around nurses, social workers, who are part of the health team?
Yeah, so I think there are definitely high rates of burnout in those professions, and particularly nurses. So, as you know, nurses are the backbone of our healthcare system. If there are no nurses, there's no healthcare. So
Yes.
they really bear the brunt of it, because as doctors, we're always flitting here and there. We're going to do our consults, we're in the wards, we're going to clinic. But nurses are there consistently the entire day, faced with patients, engaging in patient care. So they definitely bear the brunt of it, and there are high levels of burnout found in, nurses in particular.
Yeah. I came across, I think a year or so ago, I came across a study that was done by the Melinda Gates Foundation, Bill and Melinda Gates.
Mm.
It was done in the Free State. I can't remember, I think it was Pelonomi Hospital in the Free State. And they found 90%, levels of burnout amongst nurses, in their study. So which basically correlates with what you've just mentioned now, that even other members of the healthcare team, especially those who are in the backbone of the healthcare, service, which is the nurses, are actually exposed to this. I also came across another one around social workers, and it's a similar type of picture, maybe not to the same extent as the professional nurses. So what that means is that sometimes, somebody may go to hospital to seek help, and sometimes they may come across a healthcare professional who would be burnt out, and they may not be able, maybe let me ask you this: what is the likely impact to service delivery or to patient care from somebody who's got high levels of burnout?
Okay, so there's basically two components to this. The one is patient care, and the one is the impact on the healthcare system as a whole.
Yeah.
So, in terms of patient care, international studies have shown that there's a lower level of satisfaction with the care that patients receive when they interact with burnt out individuals. There's a higher risk of medical errors and litigation with these doctors who are unwell or suffer from burnout. And individuals actually, the patients, they have a longer sort of length of recovery because doctors are burnt out. So those are some of the potential complications of having burnt out individuals sort of struggling and working in the system. And then in terms of the healthcare system at large, it actually increases the cost because, as you know, prevention is better than cure. When you're dealing with already unwell individuals, it's much more expensive. Also, the increased turnover of doctors, and then just the increased workload that it puts on the colleagues around them. So those are some of the consequences in terms of the healthcare system.
Yeah. Now, you mentioned something about medical errors and litigation. And now in South Africa, we have been seeing a lot of litigation against medical doctors for what they call medical negligence. Almost all the provinces every year now, they have to make what we call contingency budgets for some of these claims against the doctors. And one wonders how much of those cases are related to people working when their mental health was not at an optimal level. But another area that I came across last year, I attended some seminar at Walter Sisulu University sometime last year on mental health. And there was a presentation that was made by Prof. Just forgotten his name now, the prof who was heading psychiatry at Medunsa, or what they call Sefako Mahato University. So he was presenting because he's a member of the health committee of the HPCSA. And amongst the things that they deal with is the whole issue of impaired doctors. So, I was quite interested in that presentation of his. And one thing that stood out for me is that the majority of the people who are, reported for issues of impairment are medical doctors. I mean, there's many professions within the HPCSA, but, GPs, interns, medical interns, student interns, and medical specialists, were in the top 5. I mean, the 5th one, I think, was the psychologists. So basically the medical doctors were 4 out of 5 of the, the top 5 groups there. And when one looked at the causes, the mental illness was by far, the reason. And within that, substance abuse was the, and so one then tries to link that with the maladaptive or coping mechanisms or escapism, and to say, well, if it is now ending up at a point where some of these doctors may even lose their licenses because they ended up adopting a maladaptive, coping mechanisms, then there's even more reason. We are short of doctors in South Africa already, and we therefore need to find ways to make sure that those who are within the system are able to contribute meaningfully, and when they get to a point where now they are actually, not in control, basically, of their life, then it becomes a worry. But anyway, Doc, as we go towards wrapping up, what message do you have just to our colleagues based on your study? Now talking, there's a number of colleagues who are watching via the various, social media platforms. What message do you have with regards to them taking responsibility for their mental health?
Okay, so I think I'm gonna repeat myself here.
Yeah. No problem.
Because
I want us to emphasize certain things, So you might have said it already, but just something like key points that they must really reflect on after they've, listened to this interview.
So I think my number one thing is stigma. I think that we really need to start opening up the conversation and destigmatizing mental illness at large, but more especially in medical doctors. And the way in which to do that is actually to educate yourself and learn about it, because it's not something that we can just snap out of or people can just get over. So stop stigmatizing yourself and stop stigmatizing others. All right. And then in terms of what you can do, just to reiterate, so the first, as I mentioned, is shifting from unawareness to awareness. So that lends itself to mindfulness and being rooted in the present moment. The second is trying to strike balance in your life, which I know is often very, very difficult, especially in the difficult working conditions that we are faced with. But striking a balance between the various components of your life, like your physical, mental, social, occupational, financial, spiritual, and self-care sort of realms of functioning. And the last one would be to connect with varying individuals and to connect with friends, and really to engage not only in this conversation but also in terms of support. And failing all that, if you find that your resilience is not coping with the amount of stress that you are undergoing, then please seek health services, because that's what they are there for. And you're actually doing yourself no favors by not doing this. And that again lends itself to stigma that we place on ourselves and we place on other people. And then at the moment with the COVID-19 pandemic, there is a number that you can actually call to get free services. And it's the Healthcare Workers Care Network, and it's 0800 21 21 21. So I would advise anybody who is not coping and not doing well, and they feel like their mental health is on the decline, to please phone that number to get some assistance. So that would be my main message.
All right. one thing I did not ask from you was the impact of COVID-19. You did your work before COVID-19, and now COVID-19 is here. How do you think it has actually, impacted the people on the front line, based on your studies?
Okay, so um, studies conducted internationally, both from a cross-sectional and meta-analytic perspective, actually show that there have been increased rates of anxiety, depression, burnout, and insomnia amongst healthcare workers during this COVID-19 pandemic. And this lends itself to a variety of factors. So isolation, so staying away from one's family, and the risk of infecting oneself, the risk of infecting loved ones, a lack of PPE, as well as being confronted with COVID patients on a daily basis, the long working hours, and being faced with death on a regular basis. So those were some of the contributory factors that were noted on a sort of global scale. And obviously there was an increased burden placed on the healthcare system at large. Locally, one study that I'm aware of was done in UKZN in conjunction with the HSRC, with Prof. Mosa Moshabela and Prof. Priscilla Reddy as the PIs. And they just looked at stress in healthcare workers during the COVID-19 pandemic. And it does lend itself a lot to the literature that has been done, or the studies that have been done internationally.
Yeah. All right, Doc. So basically, it actually worsens the situation. Absolutely. That's what it is, which then means there's more need for that kind of support on one side. But obviously, there is also a need for doctors to recognize when they're decompensating so that they can make use of what is available, to support them. All right, Doc. I think I must thank you so much for availing yourself, and I really was impressed because I've been planning to do this show, and one of the things that was making me to be a bit uneasy was that most of the data that I have was from studies that were done outside of the country. I've mentioned the Medscape one. So to actually have a study that is done here in South Africa, for me, that was quite interesting. And when I asked for your particulars from your prof, it was with that in mind. And so I just want to say thank you. Please continue on the good journey and the impact that you are making within the department, but also to the healthcare space. Clearly, it was not a mistake for you to choose psych over the other one. And I'm looking forward to seeing great things from you going forward. I hope you can also, give me a bit of energy to, I'm stalling with my own, with my own process there, with my concept note. So I'm always feeling lousy when I feel, some people have gone further and they're completing their studies, and I'm just standing in one place. So I'm definitely going to try and do more so that I can one day sit like you and be asked, what were my findings in my study and what's the relevance, to the profession and to society as a whole. But anyway, thank you, Doc, for sparing us your 1 hour of family time. Say thank you to your hubby, and I'm sure the little one is also now looking forward to being with mommy. This is is a him, is a he or a she?
Him.
The him. So he is definitely looking forward to spending time with mommy. So I mustn't take more of your time. So thank you very much, and also thank you to everybody who joined us for this conversation. I hope and trust that you picked up something from it. It's not only medical doctors who actually get burnt out, but we just wanted to focus on this, profession. But even in other spheres of life, in other professions, in accounting, in the legal field, in the business world, people do get burnt out. But we just chose to focus on medical doctors as part of the Mental Health Awareness Month. So, but everything that was shared here one can also look within their own environments and be able to say, how does it relate to my environment? And if you see that you've got those three points that Dr. Naidu shared, emotional exhaustion, depersonalization, and where your productivity is starting to go down, then it's time for you to actually seek help before it becomes too late. So I want to thank everybody, and we will chat again tomorrow. Thank you very much.
Thank you so much for your time. Thank you.
Thank you, Doc.